Hello, and welcome to the cutting edge of RNA therapeutics. I am Dr. Daniel Kiss, and I am an associate professor here at the Houston Methodist Research Institute in our Center for RNA Therapeutics. I'm joined today by Dr. Francesca Tarabali and Dr. Chiara Mancino, who will be joining our discussion, and also Dr. Christopher Brannon, who will introduce our distinguished guest.
Thanks, Dan. We're excited and honored to have our guest speaker today, Dr. Dan Peer. He's the director of the Laboratory of Precision Nanomedicine at Tel Aviv University. He's also the vice president of Research and Development at Tel Aviv University, and the founding and managing director of the SPARC program for translational medicine at Tel Aviv University. Dr. Peer's work was the first to demonstrate delivery of RNA molecules using targeted nanocarriers to the immune system. It also pioneered the use of RNA interference in the immune system, and was the first to show cell type specific delivery of RNA, of mRNA, and expression of payloads from mRNA in vivo. It was the first to actually demonstrate cell type specific therapeutic genome editing in cancer, and more recently is the first to develop an mRNA vaccine against antibiotic resistance bacteria. Dr. Peer has more than 140 pending and granted patents, and some of those have been licensed to pharmaceutical companies. One is under registration currently as a new drug for inflammatory bowel disease. His work has resulted in the spinoff of 4 companies that are innovating personalized medicine. He's received more than 35 prestigious awards, and he's on the scientific advisory board of more than 15 companies. And he's on the editorial board of more than 20 journals. So it's very busy, and we're honored that he took time today to join us for this webinar presentation. And so I'll turn it over to Dr. Peer, and I thought maybe he could tell us a little bit about his scientific journey and how he became interested in RNA therapeutics and RNA delivery technologies. So Dan.
So thank you so much. It's a pleasure to be here. Even though it's virtual, I always like the Houston Methodist, which I'm also affiliated into the nanomedicine department. So, brief or in a nutshell, I did all my training at Tel Aviv University. Started as a mathematician. I was a depressed mathematician, apparently. And then I moved to biochemistry and ended up as a membrane biophysicist during my PhD. During that time, I went to Cambridge, UK, worked with Cesar Milstein, father of monoclonal antibodies, and then spent some time with Bob Langer at MIT. And then I ended up working on integrins and leukocytes, trafficking, and generating monoclonal antibodies with Mutunu Shimaoka and Tim Springer at Harvard Medical School. During that time, the field of siRNA was just starting, and we were very much intrigued of what we can do in the delivery space. And we started with fusion proteins in collaboration with Judy Lieberman, and then ended up with liposomes. And then I started my own lab with other ideas behind us. And today, I'll tell you a little bit about our lack of understanding and where we think we really have some knowledge about how to deliver RNA payloads in a cell-specific manner. And we call it the liver exodus because basically the challenges are huge, and not everything that is considered to be extra-hepatic delivery strategy actually works. So let me walk you through this, unless you have other questions. And I hope I will explain this in a reasonable manner, because I think that the unknowns are larger than the knowns currently. So basically, this is the central dogma of biology. We all know that this is far from being super accurate, but at least this is the dogma. We have DNA, RNA, and proteins. And at the end of the day, you can see that already about 7 or 8 years ago, it was recognized the difference between double-strand DNA, although not anti-parallel to single-strand RNA. And also that RNA needs a good template, somebody to copy from. So you can see here Mr. Bean as an example. But we're very much intrigued with the understanding that you can deliver RNA payloads to organs, and more specifically into specific cells within the organs. Because at the end of the day, we're not interested in organ delivery, we're interested in cell-specific delivery within the organ. And what can we do with RNA? So this is the RNA area in the past 20 years. We can do many things. We can silence genes, we can activate or upregulate genes, like in vaccines, we can edit genes, and hopefully we'll be able to replace large chunks of genes. And for the first row, we can use siRNAs or other approaches, disosubstrates or others. And for activation, we can use a messenger RNA. We can also use a circular RNA and other approaches as well. And for editing, there are a bunch of options, including using the CRISPR system, Cas9, or other endonucleases as well. So I'm going to touch a little bit on each one of them, also looking at the challenges that we have been facing in the field of RNA therapeutics and vaccines. And I'm not going to talk about the RNA structure and the modification and all the very important things that we all know and need. But I'm going to talk about the delivery part of it. So we all know that the requirements are a lot. Actually, you need good entrapment or encapsulation or complexation or something that neutralizes the charge. An evading clearance mechanism is important for systemic administration and avoiding toxicity and immune activation unless you want to create a vaccine. But even in vaccine, you don't want to be overactivating the immune system. And the carrier must internalize or help or facilitate the internalization of the payload. And of course, the RNA must be released. And specificity is also super important. Among everything I already mentioned, there is many things we do not really know. We do not know the intracellular trafficking, exactly how it operates when the particles that have RNA payloads enter the cell. We do not really understand the immunostimulatory nature of some of the lipids that I'm going to talk about, okay? And we do not really understand how the immune system senses those carriers. After giving 16.7 billion doses of COVID vaccines, which is really unprecedented, we really don't know those basic questions. So it means that we have a lot of work to do. We also don't know how and what are the criteria to develop a strategy that upon systemic administration will not end up very quickly in the liver. We know that, lipid ratio and lipid types could change biodistribution. We also know that by changing one carbon, you can, in the lipid, in the ionizable lipid or in the helper lipid, you really go to different direction. And since this is not studied in a systematic manner, and it will take probably a few more years to understand, I think that for the young generation, this is a really interesting, exciting field to go into nowadays. So I'm advocating the use of packaging using microfluidics because I was involved in precision almost from its inception. But basically any kind of entrapment or mixing strategy, T-line or anything can work well. And, the 4 classical compounds that we all stick to, not necessarily needed, but in this way, probably most of them are are cholesterol, hyperlipid, PEG lipids, and of course the ionizable lipid. And we can talk a lot about those, but they have a lot of advantages as listed here on my right side or your right side. And if you look at this, we have three drugs drugs that are approved. One is the Onpattro, August 2018, Alnylam, Patisiran originally, which is an siRNA and lipid nanoparticle that nobody's basically using anymore because there are other options that are more patient compliant than injecting those IV. And we have the vaccines, both from Moderna or from BioNTech, Pfizer, that are giving IM, and there are a bunch of other, quite a lot of clinical trials ongoing right now. Let's talk a little bit about targeted delivery platform. When we want to specifically target to a specific cell type, there are theoretically lots of options. There are antibodies, peptides, natural ligands, including sugars, aptamers, and others. And today, due to time limitation, I will only speak about antibodies. And if you look at antibody-targeted LNPs and you're looking at chemical conjugation, there is a bunch of options in chemical conjugation. And we have tried over the past 23 years all the chemical conjugations, including click chemistry, everything you just imagine in terms of try to put on the surface, originally on liposome, then on lipid nanoparticles, and even on exosomes. We've tried to incorporate in a way that really have some uniformity, different types of antibodies with different types of chemistries. However, antibodies are not alike. Some of them has glycosylation. Some of them do not have glycosylation. It's very, very hard really to control this. And each one has its own flavor. And at the end of the day, you're ending up with a creature that looks like this. So you have FC exposure, or you have half of FC, you have thiolated antibodies or fragments of antibodies, not in the right orientation, or at least a few of them are not in the right orientation. You really cannot control the orientation. And then when you inject those IV, these creatures will be taken out very efficiently by immune cells, mostly from the mononuclear phagocytic family, neutrophil, macrophages, dendritic cells, monocytes, and they are professional phagocytes. They will do this in different ways, including using FC receptors that some of them highly express. But even not in FC receptor, they recognize those creatures and they eliminate them from the circulation very, very quickly. So we thought about creating a linker strategy, something universal, like a universal adapter for electricity. When you go all over the world with one adapter and with a simple approach, you are able to really fit all electricity outlets. So we thought that if we want to go back from chemistry, we'll go back to biology. And in biology, we looked at affinity. And basically, we can generate an antibody that recognizes the FC portion of another antibody. We do it every time we do flow cytometry. So a secondary antibody, but a monoclonal secondary. So that was our first approach. So we created, and I'll explain how, a lipidated approach, a lipidated single chain that binds any antibody from the same isotype. That gives you a platform that at the end you can control the orientation, and you only need one antibody that will be there. And then you basically just mix it in small amounts, 250-fold less on any chemical conjugation. You only need a few antibodies like this, and they're always going to orient in the right orientation. But this is version number one. Number two is to create a lipidated single chain that by itself, the single chain targets a specific receptor. So you don't need a mediator on this, and it's very efficient. I'll give you some examples. So we call this adapter We call it the asset or anchored secondary single chain enabling targeting. And basically, this is predominantly the work of Ranit Kedmi and Ofar Vaiga. Ranit now is a young professor at the Weizmann Institute. She's an immunologist, a real one. And Ofar Vaiga is in Leuven as a cell biologist. And basically, in the original form, you need three compounds. You need your LNP with your favorite payload. You need your linker, which we call the asset. And you need your favorite antibody. And basically, they operate like this. However, we have also another version that omits the antibody and just the asset, okay, have the single chain or a Fab that is also lipidated, but it's already against a specific target, a specific receptor. Normally, we want internalizing receptors. Anyhow, this approach provides the opportunity to go after different subsets of cells. So you just mix the original one with different antibodies, inject those systemically, and go to specific cell type. Very versatile platform. So for example, if you put an anti-beta-7 antibody on the surface and inject it into healthy mice, and inside you have some dye, for example, a Cy5 labeled siRNA or a Cy5 labeled mRNA, you'll go to all leukocyte subsets. If you only have an anti, for example, CD4, you'll go to a subset of T cells that express CD4. Or an anti-CD25, you'll go to the subsets of CD4s, so Tregs, and so on and so forth. So in terms of therapeutic application, we have been very much intrigued by different malignancies, including hematological ones, solid tumors, inflammation, infectious diseases, and some rare genetic disease. And I don't really have time to go with all those very large lists, but we are very much intrigued, and I'll try to give you some examples. What can you do with us? But first, let's talk about the lipids. So Srinivas Ramishetty, a postdoc in my lab that came from Li Wang, a lab in UNC, originally came with this structure that was published the year he came to my lab, 2012. And he tried to basically engineer this by changing different tails, head groups, linker, etc. And we came up with about 50,000 different lipids that encodes from 60 lipid families. And so you have a versatility of option. And basically, by just changing the ionizable lipids, you can go to different directions. And with the help of Sumo Gona Naidu, they joined my lab later on. Basically, we synthesize more of those first or second generation lipids and basically screen them in vitro and in vivo as well. And among them, we were very much interested to understand organ specificity of lipids versus cell specificity. And when we look at this, we discover something which is, very trivial. Even if you look at your specific organ like lung, liver, or spleen, and those, again, the most important part is actually not the ionizable lipid, but the ratio. But eventually, all of them are ending up in mononuclear phagocytes. And if you look at hepatocytes do not take it in a huge amount, okay? So even in the liver, and it's interesting because three different methods, right? One is using a luciferase expressing mRNA. The other one is mRNA mCherry. And the third one is a CRE mRNA for a AI9 TD tomato mouse. You will get different results because each one of them amplifies something else. Luciferase, you get amplification of the signal, which is dramatic. If you do the same experiment with TD tomato, that you have what we call amplification or genome amplification, you will get, for example, in the liver, 40% uptake or 40% expression. Whereas in luciferase, you're going to get much higher, about 70%. But if you do a TD tomato and you're going to look and sort hepatocytes, although negative selection, you will find that only less than 8% of hepatocytes express it. how can we explain this discrepancy between the methods? So if we understand the biology and the limitation, we get a sense of what is correct and what is a bit amplification of the signal. But basically for a single, I would say a single a single administration or a single screening, those tools, for example, the use of luciferase, is a fast tool because in 6 hours, when the signal actually peaks in luciferase, you will get a good sense of where your biodistribution is in a general manner. And then you need to go in deep and looking at the cell level. So what do we do with all those tools? At the end, we're interested in several diseases, and I mentioned some of them, for example, cancer. And let me give you a sense about how can we also use LNPs in finding new potential targets. So we're much interested in genomic instability in cancer. And according to Doug Hanahan and Bob Weinberg, this is, an important part, genome instability and their mutations in the hallmark of cancer. So all human cancer harbor genomic instability, and there are various forms of genomic instability. For example, chromosomal instability, microsatellites, base pair mutation, etc. And this has potential. You can target the soft spot of cancer. For example, you can target DNA repair genes or mitotic genes. And we're intrigued about this work that was done. Some of it was a screen that was done in cell lines, for example, in myeloma cells. In multiple myeloma, there was a genome-wide screen published in Cancer Research in 2011, and Shishmita, that was a postdoc in my lab, looked at this, read this paper, and was interested in this gene called CCAP5. CCAP is cytoskeleton associated protein 5. It's basically part of the cell cycle protein. It's important for mitosis. It has an important role by maintaining the centrosome integrity and the spindle pole organization and stability. Basically, the idea was if we can first silence it, knock it out, or knock it down first, then in the future knock it out, maybe we have a better therapy than Taxol, because basically it binds to the ends of microtubule. It's the same idea here that, some of the taxanes are operating. So what Shishmita done is basically prepare one of the formulation with one of our lipids and basically start to look at internalization process. Then she screened quite a lot of cell lines, and she discovered with siRNA, she discovered there are 2 types of cell lines. Cells that are susceptible for this knockdown and eventually die, and cells that lack this. What factors drive sensitivity to this target when it's knocked down? So the first idea was, let's look about the correlation of the mRNA level and cell viability, and we didn't find any correlation really. Or cell doubling time, and again, we did not find any correlation there. So it's probably not related to this. And then we went deeper and looking at different types of microscopy and looking at cells that are sensitive versus non-sensitive. And we found that sensitive cells actually has a different structure if you look at the entire microtubule and how they organized in the micronuclear formation. And we went into kinetic studies, and then, again, I'm not going to go into details. You can read this paper, but basically found that they stuck the cell cycle at the G2M. And this is an interesting fact. It happens, it's a process. It's not immediately. It happens within 12 hours, and we have followed up the kinetics. There's some movies that you can watch as well, looking really how the process works. And this gave us the opportunity to understand a little bit more about the basic biology of bipolar spindles and how metaphase is arrested in CCAP5 downregulated groups. So we really went into this. It's a collaboration between our lab and an excellent cell biology, Ronen Zeidelbar from the Sackler School of Medicine, basically trying to understand the biology behind this and how we block the cell cycle using those siRNA against CCAP5. But one of the other things that we have looked at is said, okay, let's look at this in an ovarian adenocarcinoma, an xenograph model that we run in our lab for other purposes. And basically we injected, remember, this is an siRNA, okay? So we injected this multiple times, and you can see that their tumors, the tumors are M. cherry luciferase expressing, so you can monitor them. All the tumors are intraperitoneal injected, and basically you inject your therapy at 1 mg per kilogram every 4 days initially for a few days, and you can see that the survival changed dramatically here. So this is an aggressive model. You'll see not super aggressive, but quite aggressive. So the control mice and the one that with siRNA control or scrambled sequences are dying between day 45 to 80, and the rest are continuing. We see very nice survival. But basically, we are proposing this as an interesting target. So for therapy. So Dana Tarabravsky from my lab, a PhD student, used the same target, but this time in their original screen that was done in multiple myeloma. How can we reach actually those myeloma cells in the bone marrow? So what she's done is to screen some of our lipids versus the D-Lim MC3, the Onpattro lipid, or the Moderna SM100, and to basically discover that one of our lipids behave very efficiently, and we can use this. And it's blocking the cell cycle. You can see here the arrest in G2M. This is myeloma cells. And at some point, we had to also put an antibody on the surface. We did it very quickly without our asset. We now have better data with the asset system. So this was like chemical conjugation. You have to do gel filtration. It's really, really laborious work, and also has some disadvantages. And I will explain exactly what very soon. So, sorry. So, she also had to establish a xenograph myeloma model, and she went basically and injected into the cardiac artery of cells. It's the other side of the tail vein, and basically injecting it into the artery. You can see tumors, myeloma tumors inside the bone. They also, you can see here CT. They're homing into the bone marrow very efficiently, and the engraftment is very good within a few weeks. You can also monitor many other parameters. Those special mice that have a Star Wars name, R2G2 mice, basically are the basis of this model, and you engraft the cells, and 16 days post tumor engraftment, you basically perform your distribution studies. And in this case, we use an isotype control particles or an anti-CD38 with MC3 as a control, or with our lipid 10. We also saw that they're going very nicely to the femur, but you can also see that the liver takes it. Okay, and we have a lot of liver expression. So from a proof of concept standpoint, we have huge amount in the bone marrow, about 60% more that reaching the bone marrow, but you can also see that the liver takes it very efficiently, okay? From a therapeutic standpoint, you can see that the spleen, this is with siRNA, the spleen is small compared to the control. You can get light kappa chain level that are much lower compared to control. So it seems that it has a therapeutic efficacy. Is it gonna turn into a drug? Is it something you wanna inject into human? Most likely no. And the reason is the liver. You don't want to end up with huge amounts in the liver in a non-specific manner. So if you remember in the beginning of my talk, I told you about chemical conjugation. This is a classical, chemical conjugation where you cannot control really the orientation of the antibodies on the surface. So it works very well, right? You get the therapeutic benefit, but the liver gets it all, right? You get more liver uptake than your target cells. So your off targets is higher than your on target. This will not happen with our lipidated single chain approach. I'm going to show you some data soon. So bear in mind that this is the issues that everyone that wants to use chemical conjugation eventually will have. So I'm just moving quickly to the next idea, and this is another PhD student that just graduated, and Yasmin looked at bacterial toxin as a novel local therapy for solid tumors. And the idea was, together with Professor Itai Benar, who is a great protein engineer at Tel Aviv University, is to have a sequence and a tiny amount of this bacterial toxin that coming from Pseudomonas exotoxin. Basically, local injection, you see the tumors are smaller. Actually, it looks good also in tunnel staining, Caspase-3, so apoptosis, really looks nice. But again, local therapy. Moving gear into vaccines. So I'm going to quickly talk about what Uri Ilia did, a PhD student that just graduated. He was responsible for our vaccines, from mRNA vaccines, and this is a great collaboration between our lab and the Israeli Institute for Biological Research, because as you're going to see, we have some critical bacteria or viruses that we cannot really work in challenge trials at a regular university. We need some BL3 or BL4 labs for that. So Uri developed basically an mRNA sequence that had an RBD with a human FC, and basically looked at transgenic mice having human ACE2 receptor, and had a challenge of a COVID challenge, And what you can see here that you get protection, you get antibodies from the human one. It's actually quite interesting. You get protection even if you go to 3,000 PFU. Of course, you get protection if you do 300. And that was very interesting. And 2 papers were published going all the way from the specific sequence, the formulation, the lipids, et cetera, et cetera. Okay, just to give you an idea about fast response of journals. So we were asked to write this review on the fast response of highly mutated viruses and what are the, I would say, what are the options that the community, the nano community can give. And until the paper was published, it took, you see, this was still with Omicron B1.1. So just imagine it was published in 2022, but it was submitted in December 2020. So we had a long time and a lot of review and a lot of things, but at the end it was published. And just to give you a sense, it was less relevant already, although the options, the therapeutic options are relevant, the variants are not relevant anymore. So this is how a very fast response is important also from journals, not only from viruses. But if you look at the history of pandemics, you will see that COVID represents a small fraction in history. Although about 8 million people passed away from COVID, still, if you look at the historical standpoint of pandemics, you will find that there have been others really, really devastating pandemics. The first example, and a very, very known one, is the Black Death, that almost 50% or a little more than 50% of the entire population on planet Earth were destroyed or eliminated. And over the years, you'll see the numbers. And we are very much interested, we have been very much intrigued from this fact. We wanted to understand if we can generate a vaccine for bacteria. And we been intrigued from this bacteria. It's Yersinia pestis, and this is the etiological cause of the plague, in this case, bubonic plague. And we've been intrigued from this for quite a lot of years. So with the help of Dr. Ido Cohen, a former PhD student in my lab, and Uri, that was a PhD student, we decided we're going to create an mRNA vaccine in this highly lethal pathogen. Pestis, as you probably know, is a very aggressive, virulent pathogen, bacteria. And also, if you don't treat, you can die very quickly. And there are two forms. There is the bubonic forms that normally without any antibiotics, people will die. The chances of mortality is about 50%. And the pneumonic one is about 100%. And we were very much intrigued. And I gave a talk at the mRNA conference a year before COVID. So I would say around 2019, November. And I actually talked to Kathy Carico about this, creating a bacterial mRNA vaccine. And she said, chances it will work are slim. And the reason is that bacteria brings their own protein. They don't use the cell proteins. And some of them are very smart. Some of them, for example, the one that, try to make sure that the immune system will not recognize it, are have different ways to escape from the immune system. For example, Streptococcus A, some of them surround themselves with M protein and hyaluronic acid, have this capsule, HA capsule around them. And we thought that, we have our mammalian signal sequence inside, we have our lipids, everything is detailed in this manuscript. And surprise, surprise, when you inject it into mouse, you find that Kathy Carico was right. There are no antibodies formed against our sequence. Although we do get a cellular response, an interferon response, which is high, we did not get antibodies. And without antibodies, this will not work, okay? So what can we do? Okay, so then we decided to do two tricks. One was taking out the signal peptide, so it's a delta signal peptide, and the other one is to use a human FC as a portion. And we also did another trick that is known to people who are generating mRNAs, is to do a GC-rich area inside our sequence. So creating an improved immunogen. And when we did this, we found that we get nice titers of antibodies. So we get nice titers, and we also get a reasonable, nice interferon. So a cellular response also seems to be okay. Then the challenge is, okay, let's challenge the mice. And we did. And these are 3 independent experiments, 12 mice per group, repeated. And you can see that we get 100% protection, okay? Of course, we have all the controls here, but 100% protection, we are very happy. And then we became greedy. So I'm giving you a heads up because I'm not going to show you. You have to read the paper for that. But we also got a full protection after a single dose. Why? We're still trying to understand. Highly reproducible. And this was the bubonic plague, the bubonic pestis. We have also data of 80% protection very efficiently after a single dose that we're going to finish some experiments and publish in the pneumonic one, which is much more infectious than the bubonic one. So more in this paper. And we're still very active. I'm going to switch gear very quickly just to talk a little bit about genome editing in cancer. This is predominantly the work of Daniel Rosenblum and Anna Gutkin, now in NYU, PhD students. And basically, I'm not going to go into all of this. I'm going to show you a small animation. We identify a lipid. We use two animal models. One is a murine orthotopic GBM that we got from Inderverma at the Salk Institute many years ago. And the other one is a human ovarian adenocarcinoma model. The idea behind that was that if we want to use a gene that will be a very effective one, we need to use a gene that is part of the essential genes family. The one that comes from the idea that it's like a domino effect. You hit one, you will hit everyone downstream. And this is exactly what PLK1 or polo-like kinase 1 is doing. We have been engaging with this gene for a long, long time, from siRNA to knockouts, to creating completely knockouts. We have shown that in vitro, we get about 80% or 85% editing of this gene, and in ovarian cancer, about 90%, very efficient in vitro. Then in vivo, we went into a stereotactic injection of the cells expressing luciferase, and then the particle 10 days later were injected a single dose into the brain, into the hippocampus, very gently, 2 microliters. We got a genome editing of 70%. We also did a GFP control, 70% of our gene apoptosis. Is it enough? It's not enough, I'm telling you. 30 mice per group, very big experiment, injected with PBS or with single guide GFP, along with mRNA for CRISPR in one particle, versus single guide PLK with a 60 days follow-up. These were the results. So we saw tumors, and you can see here from the IVIS, these are small tumors. It's not solving the problem, but it's a single dose. You do get some therapeutic value. So we probably wanted to inject more, but we didn't want to kill the mice because you don't want to cause edema in the brain. These are tiny mice at the end of the day. You're injecting 2 microliters. It's too much. So basically, we decided to move forward, try the other model. In the other model was a human adenocarcinoma. We use our asset system. Let me just go to the results. We got 80% in vivo editing, which is actually the highest one that was published. And we had injected 4 different groups, okay? Group number 1 with isotype control antibody in the lipidated single chain with a single guide GFP and a CRISPR Cas9 inside, mRNA. A targeted version, this is an anti-EGFR antibody, lipidated version with a single guide GFP, an isotype control with a single guide PLK1, and a targeted and anti-EGFR single guide PLK1, tiny tumor in the peritoneum, very nice survival, 90%. So very intriguing, very interesting. We saw the cells, we saw it's 90% editing in this gene. The liver is empty. We didn't see more than 3 or 4% editing non-specifically, which make our life very interesting. But before I'm ending, and I want to show you this short animation, I want to talk about the next level, the next generation. So it's not only the lipids, it's not only the targeting, it's the payload. How can we control the payload? Do we need a tRNA-based specificity? Do we need a microRNA to control the coding sequence? Do we need an iris or a toehold sequence for that? So we have started to work very hard on this in some collaboration, one of them with Jim Collins from MIT, another one with other people in this field. So trying to understand what will be the way to control the expression and open up, for example, a Cas9 only in cancer cells. so that we won't have surprises. Okay, so I've spoken a little bit about that. At the end, I want to thank my group, the people really who's doing the work, all our collaborators, spin-offs that came out of this work. And I'm going to show you a short animation, and then I'll be happy to answer any questions.
Cancer is a leading cause of death worldwide. Cancer cells divide without proper control due to genetic mutations within them. Most traditional cancer treatments are insufficient and cause severe side effects because they harm not only the cancer cells, but healthy cells as well. To make cancer treatments more efficient, we at the Air Lab have developed special lipid nanoparticles. The nanoparticles are able to recognize the mutated gene within the cancer cell and destroy it. Allow us to explain how they operate. We insert 2 RNA molecules into the lipid nanoparticle, a messenger RNA that has the instructions to build the CRISPR protein Cas9, which acts like a surgeon's scalpel, and a guide RNA designed to direct the Cas9 specifically to the target gene. On the outer surface of the lipid nanoparticle, we attach a special linker we developed called ACCENT. The ACCENT linker binds an antibody that recognizes a specific receptor on the cancer cells. After injecting the lipid nanoparticles into the patient's body, the antibody directs the lipid nanoparticles specifically to the cancer cells, sparing the healthy cells. The Cas9 mRNA is translated inside the cell to the Cas9 protein, and then assembles with the guide RNA. The Cas9 guide RNA complex enters the nucleus and locates the mutated gene within the cancer cell's DNA. Once recognized, the CRISPR scalpels cut the gene and permanently disrupt it. The treated cancer cells can no longer divide, no matter how much they try, and eventually die. Our highly effective and precise approach can revolutionize cancer therapy and improve the quality of life of cancer patients.
Okay. Thank you. And I'm happy to answer any questions.
Thank you, Dr. Pierre. Definitely an amazing presentation as usual. I will stay here hours to comment all the different works that you show, but I have more some questions related to some of the all unknown that we know, and you mentioned also we don't know more than we know in this field. So one of the struggle that we in the nanoparticles world have is sometimes related to people that don't do this work, or they just facing this part of the field right now because mRNA technology actually put a lot of hype on this part. Is how is important that the drug delivery system, and you show with your work, and you show for a long time with your work how is important the drug delivery system to address what we want. Now the question is, how is important to validate the system in vitro rather than collect more evidence in vivo? In your work, you do a lot of in vivo rather than in vitro, but sometimes we friendly fight with our coworkers or also regulatory people that say, oh, you have to prove this in vitro. But actually, how different is the reality of testing these steps in vitro and understanding something in vitro that I still believe is something that we have to address, like what you show, CRISPR-Cas9 is the construct work, but how we can get from the in vitro rather than in vivo, and what are the limitations that you show with your model, for example, the multiple myeloma of the in vivo system that we have right now to translate in human. Probably too much complicated.
Okay, thank you, Francesca. I think it's a very important question. Unfortunately, I think that in vitro models can only give you what in vitro models can give you, which means you will get a sense if your, let's say, your delivery system gets into the cell. That is either silence a gene or upregulate a gene. You can also get information about some immune response if you're using macrophages or other types of cells. So you can look for cytokines, for interferon responsive genes, anything related to particular cells. The translation from in vitro to in vivo is by far problematic. Okay, so it's not necessarily mean that if you're going to see wonderful results in vitro, it's going to be translated in vivo. And I would say even the opposite is correct. So we do know of certain events that in vitro, the results are okay, but not stellar. And in vivo, it works much better. And that probably could be that there are some other factors that help the particles in vivo, stabilize it, maybe protein coronas that are sticking to it and homing it to somewhere. I mean, there's so many things, but from a chemistry standpoint, we learn over the years something that all the people in the AI field will not like to hear. We learned that when you change a single carbon anywhere in the head group, in the linker, in the tails, even a single carbon change or could change completely the biodistribution, the toxicity profile, and even the efficacy dramatically by changing one carbon.
I can second that.
Since
I
we
saw
don't
that.
really understand this, we will need probably, maybe AI in the future, machine learning in the future, that will have, millions of data on this, could screen something and have a better understanding of what are the requirements. But currently, with all the published data, patents, and everything, we are kind of stuck because we cannot really predict what will be stellar and what will be disaster. And I can give you one example from one of our lipids that is now tested in the clinic, that if you change one carbon, you're going to get twofold less efficacy in your LNP. Twofold in one carbon.
Okay? It's amazing.
So that's amazing. And also the biodistribution will be changing. So I think that there's so many parameters that we need to do, but basically your questions on in vitro is you can learn a lot of things. The question is, the applicability from in vitro to in vivo, which I think should be tested. But if, of course, you don't get any transfection, don't try it in vivo.
Yes, exactly, as a check. But a lot of people say, oh, okay, I can assess the dose, for example, for an siRNA approach. I can assess the dose in vitro and then transport in vivo, but it's actually not the case. The dosage is like totally all over. And as you mentioned, it can be that in vitro doesn't work, while in vivo you see you see your carrier work. So, and this is very important, especially for me. So every time when I talk with you and I hear from you, I always say, okay, it's not just me. It's everybody that I'm thinking this way, and this is important. Regarding the animal model, and especially animal model in infection disease and mRNA infection disease, how this is instead difficult to have an animal model that can be translated, especially for your Yersinia pestis work?
Yeah, so vaccines are less of a problem because actually what you see in animals, these are mostly healthy animals before you infect them.
Mhm.
So the problem is you have to find a lab that can work with animals that are infected with a pathogen that can infect you and kill you as well. So
Yeah.
this is not a simple task. This is why universities are not really good at that. So you have to collaborate with places that have this. But you are in Texas, and I think you're close by to the
We work too with UTMB for
Exactly. UTMB is a good example of a place that have those pathogens and they can work with them, and yeah.
Chiara, do you have some questions?
Yeah, not sure how much time we have. I'll be brief, but I was actually wanting to touch base on something you mentioned at the beginning of your talk related to immunogenicity. And I was wondering if you could touch base on the differences, if any, of immunogenicity profile triggered by cationic lipids versus ionizable lipids, and which ones you think are best for which applications, meaning if
Okay.
immunogenicity profile matters for vaccines for cancer rather than for infectious diseases.
Yeah. So fully charged amines are or could be super immunogenic. Okay. Could be. We discovered in 2010 that fully charged amines such as DOTMA, DOTAP, and all those family agonize toll-like receptor 4. And basically having all the signal transaction downstream. So you'll get all the interferon response, pro-inflammatory cytokines, it does everything. Later on, some people proved that, of course, TLR2 is also involved. And that makes sense, right? TLR4 and TLR2 are working together. These fully charged amines are disaster at some point. This is why the field of ionizable pH sensitive came really into place. I would say that we still don't know how. We have some predicted markers, and you can read a paper that is just online from yesterday that we published in Advanced Drug Delivery Reviews on the immunostimulatory nature of mRNA lipid nanoparticles. And if you look at this, we defined it into what the lipids can do, what the ionizable, the helper lipids, the PEG lipids, et cetera, what the mRNA can do. So I think that you'll get more information, but basically everything could signal at the end, right? And everything could be sensed. The question is to fit your mission. You want to be immunogenic, you need to be, okay, you want to develop a vaccine, you have to be immunogenic. How much immunogenic? That's a different question. You don't want to be immunogenic, you want to be stealth-like, then you have to screen for lipids or for molecules that are more quiet. Always they will do something, but you want to screen for the ones that are less aggressive, less problematic.
Thank you. I think there's someone else from the audience.
Yeah, amazing talk. I would like to keep on this subject about immunogenicity related to your nanoparticles that have an antibody for targeting. Also, because my impression is that when you target tumors and you target genome stability, what you get is not tumor relapse, but tumor stabilization. So you really need several injections to keep tumor growth control, right?
Definitely could be, yes.
So do you see immunogenicity against your nanoparticles that have antibodies targeted to
So first, the one that have lipidated single chains, you can inject multiple times, and we haven't seen yet. But these are not in the clinic, so we don't know. If you incubate them with human PBMCs, you will not see. Okay, but if you do chemical conjugation with an antibody, then you will see, because antibodies are formed against the antibodies, and in the second and third and fourth dose, you will see an ADA, antibody-drug antibody, and the antibody will be, the particles will be eliminated from the circulation, and you will see less efficacy in time. This is why I'm trying to advocate not to use chemical conjugation on antibodies. There are other reasons, but this is one of them. But the question you want to ask yourself is, what is the purpose of using a targeted system? And if the purpose is to edit a genome, then you have to do it once or twice. You don't have to do it every week or every month, right? You probably in cancer will have to do a kind of metronomic therapy. You'll have to do it in a pace that will be, or a maintenance therapy once every time. But eventually in cancer, they're combination therapy. So you'll have to go to different types of basically a combination.
I want to thank Dr. Peer for that beautiful presentation, and our guests and our discussants. And I think it's amazing work, and thanks everyone for tuning in. Again, this is the cutting edge of RNA therapeutics, and hope to see you next time. Thanks.
Thank you.